Good morning, everybody. My name is Giuseppe Ziniti. Thank you very much for giving us the opportunity to present my research. Let's start with some epidemiologic data concerning obesity. Obesity, whose rate is increasing worldwide, and this increasing is associated with an increased rate of cardiac and respiratory comorbidities, metabolic syndrome, and fatty liver disease, as well as steatohepatitis, which affect respectively the outcomes of general surgery and more specifically of liver surgery. And concerning impact of obesity on liver surgery outcomes, we have in literature contrasting results, probably related to selection bias, with some studies showing similarities of postoperative outcomes between obese and non-obese patients, and other studies suggesting worse outcomes among obese patients compared to non-obese. And recently, few papers have tried to assess, to investigate impact of surgical approach, so the minimally invasive liver surgery versus the open liver surgery on outcomes of liver resection in obese patients, and what the study, which are small and include a small number, few patients, and are based on non-standardized obesity definition and on imbalanced patients and disease characteristics between males and adults. So what this study show is that meals is safe, is cost-effective, and sometimes have also better outcomes compared to others. Let's come to our research. This is the patient selection and study design. So starting from a large database of 15,000 patients who underwent liver surgery at 16 centers in 8 countries from 2000 to 2009, and after exclusion of patients due to the enlist reason, finally 7,000 patients were included in the study and were divided in 5 BMI classes, and characteristics and outcomes of patients according to BMI were compared, and in each BMI classes, the characteristics and outcomes of meals and all patients were compared with each other. And finally, propensity score matching 1-to-1 of meals versus souls in each BMI classes was performed based on demographic, clinical, pathological, and surgical data, and the resulting patients were compared with according to the surgical approach used. And let's go rapidly to the results. We can see that the comparison of patients according to BMI show that increasing BMI was associated with decreasing age of patients, decreasing rate of cirrhosis of preoperative PBO, preoperative chemotherapy, and past extrahepatic abdominal surgery, and decreasing rate of malignancy disease for which the patients were operated, and of multiple tumors. And increasing BMI was also associated with an increased use of minimally invasive approach of major people resection of duration, and of intraoperative blood loss. However, all these characteristics were associated with just with an increased risk of wound-related complication, but also with a decreased risk of bile leak, increasing the BMI patients of liver failure, and with also a gradually shorter length of stay in association with increasing BMI. When we look at the patient comparison according to surgical approach in the overall population, what we can find is that patients undergoing open resection compared to minimally invasive resection had higher rates of as a score higher than 2, preoperative chemotherapy, and the previous liver surgery and preoperative use of PPO, and also had larger tumors, had a more higher rate of multiple tumors, and more frequently had a positive surgical margin and were operated for malignant disease. When we look at operative characteristic and post-operative outcomes in this unadjusted comparison, what we can find is that all patients undergoing open resection compared to minimally invasive resection more often underwent major resection, more often underwent major concurrent procedure, and consequently had longer operation duration, had higher intraoperative blood loss, and higher rates of intraoperative packed red blood cell transfusion, and these characteristics went in parallel with higher rates of overall complication, of major complication of mortality, 90-day mortality, and longer length of stay were observed as a result in the open liver surgery compared to the minimally invasive liver surgery. And as we can see, after balancing of patients and disease and surgical characteristics by propensity score matching many of the differences which could be observed in the previous table disappeared, both in clinical demographic characteristics and in pathological characteristics, and also in operative characteristics. But anyway, differences in terms of operation duration and intraoperative blood loss and need for transfusion, intraoperative transfusion persisted, with all these characteristics being more frequently observed in the open group compared to the minimally invasive surgery group, and paralleling higher rates of overall complication in the open group compared to the minimally invasive group, and longer length of stay in the ORS patients compared to the NEOS patients. So these are the take-home messages. Higher difficulty related to increasing BMI is not paralleled by worse post-operative outcomes. And in the overstudied population before propensity score matching, all patients had more advanced disease and needed for more challenging procedures paralleling worse outcomes compared to MIRS patients. And among MIRS patients, better perioperative outcomes, faster recovery following propensity score matched balancing of patient disease and surgical characteristics suggests that MIRS compared to ORS may be of benefit independently from patient BMI. Thank you very much for your attention. Bye.